you very much. First of all, I would like to thank the organizers for inviting me, and also to congratulate CRI for this. I would say this one-day sports gallery meeting is one of the best educational meetings in sports gallery there is, actually. So thank you. I'm going to talk about prevalence of coronary artery anomalies and data from CT database that we have creating in our country. With the causes of sudden cardiac death in young athletes, coronary artery anomalies are associated with deaths in between 15 to up to 35% in different studies. And looking as an example here, the study by Maron showing 17%, and this is in young athletes. Specifically, some of the coronary artery anomalies are associated with a higher risk and others less so. For example, these two other types who has been associated with sudden cardiac death is the anomalous left main coronary artery, in this case originating from the right sinus, as you can see here, and both coronary arteries from the right sinus. And the other type has been the ARCA, or the anomalous right coronary artery, in this case originating from the left sinus of a salva and have separate origin from the left coronary. So these two types, and these are also with the vessels, with the course of the vessel being intra-arterial. So the prevalence of coronary anomaly is, the true prevalence is not known, because the studies has been done in selected populations where you do CT angio, or, for instance, or angio. So 0.3% in adults undergoing coronary angio on clinical grounds, which is a selected population, of course, and also 0.17% in children undergoing echo for various reasons. So what we really need to know the true prevalence is a study in a large unselected population. Coronary anomaly was first described as being associated with sudden cardiac death in the 70s by Dr. Scheitlin, who described a 70-year-old male who had sudden cardiac death post-exercise, and he had an anomalous left main coming from the right sinus, and it was described in the paper that the course of the vessel was partly intramural and also having a narrow orifice. And this was in the 70s. So the symptoms, most of these patients may be asymptomatic before a case of sudden cardiac arrest and sudden cardiac death. Around 1/3 is thought to have symptoms before, including chest pain during exercise, palpitations, syncope, and dyspnea, and all these symptoms exercise related. But of course, most of them are asymptomatic before maybe sudden cardiac arrest even. So, looking at diagnostics, the normal 12-read resting ECG will in these cases not be. We have seen all the evidence for ECG screening before, but in most cases the normal resting ECG will be normal. Maximal exercise testing could reveal ischemia or arrhythmias during exercise, but in clinical practice, the most common way of suspecting coronary artery anomaly is probably transthoracic echo, because part of screening or secondary evaluation and so on for symptoms, and then you have to go further to confirm the diagnosis, perhaps by CT angio, cardiac MRI, or coronary angiography. So is it dangerous? All the autopsy cases collected in the US Armed Forces Institute of Pathology, they looked at the coronary artery anomalies, and they can only find 51 cases here in 475,000 autopsies. But 33 of them were anomalous left main, and 18 were anomalous right coronary. And as you can see here, none of the anomalous right were associated with sudden cardiac death, and only the anomalous left mains. So it was thought in the beginning that only the anomalous left main were the dangerous ones, so to speak. The possible mechanisms of cardiac arrest is pure speculation. It's theoretical and hypothetical, but it could be that the vessels either have a sharp angulation, have an intramural segment with increased pressure, have a spasm or a slit-like orifice. It's also been suggested that maybe the artery gets squeezed between the great vessels, and all these will lead to ischemia and arrhythmias as the lead of cause of death. but we don't really know. But then again, some evidence emerged that maybe also the anomalous right coronary artery passing between the great vessels might be not so benign after all. And this is also a selected population of 1,200 Italians having congenital heart disease, which you might expect a larger degree of coronary anomalies perhaps, and they had 0.9% having coronary anomaly, and 4 of those had anomalous left main, and all these were associated with sudden cardiac arrest, and 3 out of 7 also of the anomalous right coronary arteries were associated with sudden cardiac arrest. So maybe the anomalous right is not so benign after all. So this is actually a case of an anomalous right described in the European Heart Journal in 2012, 39-year-old runner who died during a half marathon, and he had anomalous right coming from the left sinus, and it also passes, I don't know if you can, intramural pathway. And this is actually the oldest athlete or case actually described being associated between two sudden cardiac arrest or sudden cardiac death with coronary anomaly. So then raises the question, is coronary anomaly existent in older people, or is it suddenly benign after you turn 40, or what will happen? So we use the large Scandinavian image study now, performed currently in Sweden, and it's actually a Swedish image study. Non-selected population, 50 to 64-year-olds, they will perform a lot of imaging for 2 whole days, but including CT angio in all these people. And for the data, well, preliminary data I present now is from the pilot study from the first 980 cases from the Gothenburg area. And we wanted to look specifically at the prevalence of coronary artery anomalies, the total, and also the different types. And also if this is, to ask if this is really present in the middle-aged population, because no cases has been described with sudden cardiac arrest. So this is the first case. I'm excused for not being an image expert or not being the pathologist here, but what we can see here is the anomalous left main with an interarterial course, and you can see that both coronaries go from the right sinus or come from the right sinus. Another case, we have the anomalous right, and if I show you the coming slides, you can see here that where the vessel emerge between the vessels like that, and courses interarterially as well, and both coming from the left sinus. And you can show another picture here that you can see the both, and part of it is intramural, and they come from this left sinus in this case. And the third case is, again, an anomalous left main, but here is the circumflexa is behind the aorta. And here is also anomalous left main, but then the vessels are not coursing between the aorta and the pulmonary trunk, so this is considered to be more benign, as not been associated with sudden cardiac arrest. So, in these preliminary results, we can show that I've highlighted the ones who are considered more malignant, or so to speak, dangerous and associated with sudden cardiac arrest. You have 2 cases of anomalous left main and 2 cases of anomalous right coronary artery. And also you have some other variants of coronary artery anomalies, which some of them are not considered to be dangerous at all, but we still want to list them all, and then comes a large definition work to see what is truly a coronary artery anomaly or not. But in summary, the more malignant ones is 4 out of 980, and that corresponds to around 0.4%. And of course, depending on how you define the rest of the coronary artery anomalies, they are around 1%, even in the middle-aged population. Which is interesting because now we have currently performed 23,000 out of the 30,000 CT angios in the normal population in the country, but these involves different university hospitals. We will in Gothenburg include a total of 7,400, so then we can try to look at them specifically, or possibly the whole cohort, of course. What we can do when we have the larger cohort is look at subgroups, looking at the ages, and also gender. So we have a lot to work to do that and do subgroup analysis. But even more importantly, we can also look at the outcome. We can follow these people and see what the natural course of having coronary artery anomaly in the middle age will mean for you. Because it might be an underestimated cause of sudden cardiac death in older people. For instance, in our country, if you have a sudden death and you are under 35, you will by almost 100% certainty have an autopsy. And then you will find these coronary artery anomalies. But if you are over 50 or 60, perhaps, and you have a known coronary artery disease, and you have a malignant arrhythmia and die suddenly, you will not be routinely having an autopsy in our country, and you will be probably attributed to this coronary artery disease. So I think you may have an underestimation of some of these causes might be for coronary artery anomaly, possibly. So we can look at that. And I think we can do that in the coming years. Thank you very much.